Good morning, everyone. I'd like to welcome you all to this third meeting of the North Carolina Council on Healthcare Coverage. We have a lot to cover today. Really appreciate everyone taking the time. And to get us started, I'd like to turn to Governor Roy Cooper. Governor.
Well, good morning, everybody. And thank you so much for the work that this council is doing. I know these issues are complex, and I appreciate the forthrightness, the hard work that you all have put into this. I particularly want to thank our healthcare providers who are on the call with us today. They have been on the front lines of this pandemic, and I'm grateful for their hard work. And I want you to all to know that the number one priority in my administration right now is making sure that we distribute this vaccine as effectively, efficiently, and quickly as we possibly can. And we appreciate the hard work that our hospitals and health departments and other providers are putting into this work. It's complicated and difficult, and I'm grateful for that. I think the guiding principles that hopefully this council can come up with are going to be critical. These healthcare issues are complex, and I know that we come at this from some differing points of view, but it's really time for us to address these issues head on, particularly in the middle of this pandemic, finding ways that we can leverage every dollar to make sure that every single North Carolinian can be able to see a doctor when they need to see one, and to really provide support to our healthcare providers out there who are working hard every single day. Thank each and every one of you for your input into this. I look forward to getting guiding principles from this council, and then the hard work of working with the legislature, working with our federal partners, insurance companies, the private side, the small businesses that have been so hard hit by this pandemic, trying to help them and their employees. And I just want to say how grateful I am and look forward to the guiding principles from this council.
Thank you, Governor. I really appreciate your taking the time with everything else that's going on, and our legislators as well. Secretary Cohen, would you make some opening comments, please?
Well, good morning, and thank you all again. Yes, it's been incredible work that's gone on in between meetings, and I want to thank everyone for their engagement, not just at these meetings, but in between as well. Today's conversation is going to be about financing, which gets weedy, so hang with us. And I want to thank Julia Lurch from my team, our chief actuary and head of policy for Medicaid, for getting into some of those weeds, but doing it in a way that I hope will be accessible for everyone. And then I look forward, I think most importantly, to our small group conversations where we can get into small groups and really get into some of what the governor was mentioning about of these principles. Because as I talk to each of you one-on-one, there is so much shared understanding about how to help North Carolina move forward. I think with codifying that in a set of principles, that will be really helpful to our work as a foundation going forward. So thank you again to Mark, and particularly to Jaime at Duke Margolis for all the work that they continue to do to support the council. So thanks so much. Look forward to the discussion.
Thank you, Secretary Cohen. And this really has been a team effort, including not just our staff, but all of you who have been contributing time. And I'm going to spend a minute just giving you a preview for the agenda. This was sent out ahead of time. There's one important modification that I want to mention. We had originally intended to, based on interest, provide some perspective on Montana's experience with coverage expansion plus voluntary work requirements, financial implications, and things like that. For logistical reasons, we're not able to bring them to you today. We are going to try to include that at a later session. And I think that's okay because it gives us plenty of time to discuss some of those options for improving access to quality coverage that we talked about, especially in the last meeting. That was a great discussion last time. I got a lot of ideas on the table, including various forms of coverage expansions, as well as other steps to make more, potentially make more affordable options available to North Carolinians, including association health plans, including steps to create more competition to try to bring costs down. And so today we're going to review from a financial standpoint what the evidence is and what the implications for state budgets and for other costs would be of these different options. And then we're going to go back to where that brings us on our guiding principles. As the governor talked about at the beginning, this is an important part of what we're trying to do in this effort to find some common ground and not necessarily reach consensus on a specific proposal, but help us move forward with some constructive discussions at a time when, in the midst of the pandemic, with people really struggling with their healthcare costs and needing access to innovative care, telehealth, vaccines, as the governor was saying, other ways to prevent the serious health consequences that have been associated with the pandemic, ranging in all areas from chronic disease management to increased occurrences of substance abuse problems, opioid hospitalizations and deaths. Some real opportunities here based on this group getting together and having some common principles. And then we're going to spend some time in breakouts for smaller group discussion and come back together to talk about what we've learned. And that will hopefully tee us up well for our next meeting, where we hope to get to towards consensus around these broad guiding principles for further work in this area. So that's an overview of the day ahead. And without further ado, I'd like to turn to Julia Lurch. As you heard, she's Chief Actuary and Head of Policy at the Department of HHS, and will be at North Carolina Medicaid. And so we'll be talking to us about these different options. Julia, I know you put a lot of work into this.
Thank you, Mark, and good morning, everyone. It's my pleasure to be with you all today. As folks have said, I've been asked to share and present an analysis of the options that we've been discussing as part of the council. We'll be talking about the populations that are targeted, the estimated costs, and the potential financing mechanisms for those various policy options. Just to note up front, so the list of options that we'll go through are on this slide here. These options are not necessarily mutually exclusive. Some of them could be combined. So some of these could be done in combination. So just keep that in mind as we go through the presentation. As noted by the opening speakers, these issues are complex. There will be a lot of information on these slides. I'm going to go ahead and apologize up front because it may be overwhelming, but just to let you all know, there is a slide at the end which brings it all together, so you don't have to take too many notes. We're gonna wrap it all up at the end and show what these options look like next to each other, so you'll have a bit of a cheat sheet at the end there. I'll also pause for questions as we go because this is a lot of information.
And Julia, if I could just remind folks, please chat your questions also while she's speaking, because when Julia takes a break, we will make sure we read those questions aloud. So if something pops into your head and you want to just chat it, just please do that. Thank you.
Thanks, Amy. So if we can go to the next slide. So before we get into some of the cost estimates, we did want to just go back and do a review of the health coverage environment in North Carolina. You know, behind every dollar that we spend on healthcare are people. And so just a reminder of the folks that we're talking about and what the health coverage looks like in North Carolina, just to provide a frame for the options that we're talking through. So this graphic shows the types of coverage that North Carolinians had in 2019. We know that things have shifted as part of the pandemic, but we don't have that data to share just yet. As you can see here, nearly half of North Carolinians are enrolled and get their health coverage through their job, either their own job or a family member's job. That green block, which shows 46% of North Carolinians have employer-sponsored coverage, includes a mix of coverage through small businesses and large businesses, providing a mix of coverage through fully insured products and self-insured products. We'll talk a little bit more about that as we get into some of the small group options that we're considering. Here, when we talk about small groups, we're talking about employees or employers with up to 50 employees. As you can see from this slide, 15% of North Carolinians are enrolled in Medicare. Medicare covers older adults and individuals with qualifying disabilities. And then the Medicaid program covers 18% of our population. The vast majority of those are children. We do cover parents up to a very low income level, and we'll talk about that on a later slide. Actually, we'll go through all of the Medicaid populations in a couple slides here. And then we have 7% of our population enrolled in the individual market. So those are folks that are purchasing coverage either through the marketplace, which is healthcare.gov, or directly through insurance companies. And then we have the remaining 12%, or about 1.2 million North Carolinians who are uninsured. So that's our coverage profile in North Carolina, just to provide a frame for the options. On the next slide. This next slide, we dig into the distribution of the North Carolina population, both in total and the distribution of our uninsured population by income. So as you can see from the slide, a disproportionate number of low-income individuals in North Carolina are uninsured. So to read this, while 13.5% of our population has incomes under the poverty level, 24% of our 1.2 million uninsured are under the poverty level. On the right-hand side, there's a little bit of a description around the programs, the public programs, especially that those folks are eligible for. So for adults, especially who are uninsured in North Carolina and under the poverty level, they generally don't have access to any public coverage unless they meet the specific eligibility categories for Medicaid, which we'll talk about on the next slide. Then the two middle income groups, the folks between 100% of the federal poverty level and about 400% of the federal poverty level, they comprise another 60% of our uninsured population. Some of the folks in that group may have access to employer coverage, but they may be uninsured because potentially their premiums are out of reach. On average in North Carolina in 2019, employee premiums for single coverage was about $1,500, and that's on average, so that varies a lot by employer. It's, I think, important to note that for the lower wage quartile, so those in the lower 25% of wage earners, their contributions to employer coverage are actually higher. They're closer to $1,800. So you can think about what that might mean for someone who's lower income and why they may be uninsured rather than purchasing their employer-sponsored coverage. Those without coverage options through their employer are generally eligible for premium tax credits on the federal marketplace. Although some of those folks may find that to also be unaffordable, especially when you consider the associated cost sharing that's involved in that coverage. And then finally, the higher income groups, so those with incomes above 400% of the federal poverty level, they make up about a third of our total population in North Carolina, but fewer than 15% of our uninsured population. And these folks with incomes over 4 times the poverty level are also not eligible for federal tax credits on the marketplace. If we could go to the next slide. I noted that we would touch on the current North Carolina Medicaid eligibility. So we've reviewed this in past meetings, but just a reminder that while Medicaid covers children up to about 210% of the federal poverty level, adult coverage is limited to pregnant women with incomes up to about 196% of the federal poverty level. And that coverage begins when the woman is pregnant and ends 60 days after birth. And then we cover people with disabilities and older adults under the poverty level. And then parents with incomes under 42% of the poverty level. And you can see that how those annual incomes work out on the right-hand side there. And then just to note that currently Medicaid does not cover adults who don't meet one of those categories. So parents, people with disabilities, or pregnant women, regardless of their income. All right, I'm going to pause there and just see if there are any questions on the environment before we move into the options.
Any questions from the council members on any of that? No? Okay. One question I had, and thank you for clarifying that, Julia. So just so I understand it and looking at this, for the pregnant women, so 60 days after they have the baby, they're no longer eligible as a pregnant woman. So they would essentially have to qualify as a parent at 42% of the federal poverty level or lower in order to stay on Medicaid. If not, they lose coverage. Is that right? Or
That's
Medicaid
correct.
program?
Yes.
Okay. And so just to add on to that, you know, in terms of looking at, okay, what could they do to get coverage through the exchange? I know you're going to get to that, but I think that'll be something to think about, you know, where the gaps are for different groups as you all think about where your gaps are in coverage in North Carolina. So other questions or comments before we go on?
This is Tunde. Just a comment. I was just looking through our initial enrollment numbers in the individual under 65 ACA market. And you might recall the last meeting I had mentioned that at least through 2020, we covered actually 92% of the individual under 65 ACA marketplace, and about over 80% were fully subsidized. And it turns out that we have seen a drop in our fully subsidized. It's probably close to 65,000 members that have dropped off the rolls. We expect about 15,000 will come back onto the rolls, but that probably leaves at least 50,000 members that probably today are in the uninsured pool. So the point is, I'm under the impression that our uninsured problem just got worse.
Thank you for sharing that.
Okay.
That's a good data point. Thank you. All right, so now we're going to move into the analysis of the options, starting with the individual market reinsurance program. And so if we could go to the next slide. Thank you. As a reminder, we talked about the reinsurance program last meeting, but again, the reinsurance program addresses health insurance premiums for individuals purchasing coverage either through the marketplace at healthcare.gov or purchasing directly through an insurance company. This program is not for individuals getting coverage through their job. The reinsurance program works by reducing premiums by taking some of the claims risk, usually for high-cost individuals, away from the insurance companies into the reinsurance program. And so by shifting that risk to the reinsurance program, insurers are then able to reduce their premiums. So that's the basics of how a reinsurance program works. A little bit of background here on our individual market, and Tunde may have more information or better information on this, but this is what was available out publicly. So you can see from this this pie chart that 25% or a quarter of individuals on the individual market are getting their coverage outside of the marketplace, so directly through insurance companies, and then the remaining 3/4 purchase their coverage through the marketplace. And of those on the marketplace, the large majority are have incomes between 100 and 400% of the federal poverty level, and thus they qualify for federal premium tax credits or subsidies to help pay for their premiums. Also included on this slide, just again for background, are some of the key statistics for those who are eligible for subsidized insurance on the marketplace, and these are all from 2020. But the first thing to note is that the average premium for subsidized individuals on the marketplace in total was $675 per person per month. And on average, 606 of that was covered by the federal tax credits or subsidies. The tax credits are sliding scale, and so the subsidies are higher for individuals with lower incomes and lower for individuals with higher incomes. So those in the lower income bands have subsidies higher than that average 606 per person per month. And so these are really just numbers to keep in mind. Later in the presentation, we'll compare those to some of the other options, but just a data point to provide some background on the individual market. On the next slide, ooh, I think we maybe skipped ahead. Is there another slide in there? All right, it seems like we may be missing a couple slides.
Yeah, and those slides are important because you walk through. What happened?
I don't have.
Yeah, we have to get. I think we're just going to get the right deck. So, hey, just give us a moment. Thank you.
Maybe we'll see if there are questions again while we're waiting for the slides to come up here.
Yeah. There we go.
Okay, perfect. Thank you. All right. So this slide and the next slide, we're going to walk through some examples of what the reinsurance program would mean to a sample individual. And in this example, we pulled a single 45-year-old residing in Hyde County just to provide for illustration to show what marketplace coverage means for this individual at various income levels. So we show on this slide what their premium looks like and their out-of-pocket costs. And we focus on the second lowest cost silver plan on the marketplace, which is the benchmark plan that's used for determining federal subsidies. Other options at other metal levels are available to folks to purchase, but it was too much to put on one slide. So we're focused on here on the benchmark silver plan. As we noted before, the federal tax credits are available for individuals with incomes between 100 and 400% of the federal poverty level. Those tax credits are not available to individuals under the poverty level or over 400% of the federal poverty level. So as you can see from this example, in Hyde County, a 45-year-old, the silver benchmark premium is $767 per month per person. And at the lowest and highest income levels here, there's no federal subsidy that's applicable. So if someone under 100% of the federal poverty level or over 400% of the federal poverty level wanted to purchase coverage through the marketplace, they would have to pay the full freight, the full premium of $767 per month.
And Julia, can I just stop here for a minute, just because I think just to make a link from like the pregnant women example you were talking about in Medicaid. So, you know, a woman who loses coverage who may be at, 70% of the federal poverty level, let's say 60 days after she's had a baby, she would have the option to get exchange coverage, but she wouldn't be subsidized. So that is one of the gaps. She would have to pay $767 a month, which would not be affordable at that low income level. So just wanted to kind of make a connection of where, the Medicaid program currently stops and where the marketplace picks up and subsidizes and where there's that gap. So go ahead.
Thank you. That's right. All right. So we talked about, so for individuals with incomes in the range for tax credits on the marketplace, the premiums for consumers are actually linked to their income and not the actual premium. So as you can see here, for someone that's at 130% of the federal poverty level, if that's their income level, they would pay $29 per month for the silver benchmark plan. And that is calculated as 2.07% of that person's income, not tied at all to the premium. So if the premium is $2,000, they would still pay $29 based on their income. And then you can see for someone at 250% of the federal poverty level, they pay a higher percentage of income. These subsidies are sliding scale and higher at the lower income level. So at 250% of the federal poverty level, this individual would need to contribute $221 per month for their coverage. And then the federal subsidy is basically calculated as the excess. So if you take the premium minus or if you take the full premium minus the consumer's portion, then you get the federal subsidy. And you can see those vary by income. Also important in terms of the marketplace experience is the cost sharing that's applicable to the plans that are being purchased. So for individuals between 100% of the federal poverty level and 250% of the federal poverty level, there's a program that allows for reductions in cost sharing. And here, when we talk about cost sharing, we're talking about copays and deductibles and coinsurance. So folks in those 100 to 250% FPL range have higher value plan, but lower cost sharing. So a 94% plan means that on average, someone in that plan pays 6% of the total service cost out of pocket. Someone without that cost sharing reduction eligibility for the folks below poverty and above 400% of poverty, they are getting a 70% plan, which means they pay on average 30% of their service expenditures out of pocket. And that can add up quite significantly. So in this example, on average, the 70% plan means that the average person enrolled in that plan, they would have or be subject to cost sharing of about $2,200. And that would vary based on the level of healthcare services that are used. In all of these plans, the out-of-pocket costs are capped. Where folks are eligible for cost sharing reductions, they're capped at a lower amount. So those in the lower income range at 100%, I think up to 200%, they're capped at $2,850, and then for those between 200 and 250%, they're capped at $6,800. But the cap for those that aren't eligible for any subsidy is $8,550. So we all know health insurance is expensive. It's not necessarily affordable at those rates for someone at 400% of the federal poverty level, but for someone under 100% of the federal poverty level, if you add up those things, both the premium and their out-of-pocket costs, it exceeds their total annual income. So it's pretty clear that that would be out of reach for someone at that income level.
And Julia, there was just a question from Cassandra just to confirm. She asked FPL, she would not qualify for Medicaid because she was not under 40%.
I'm sorry, I missed that, Amy.
Oh, we just wanted to confirm if a woman was under 100% of FPL, she would not qualify for Medicaid because she was not under 40%. So just wanted to confirm that.
That's correct. So if you're between the 40, it's 42% and 100% of FPL. Even if you're a parent, you are not eligible for Medicaid in the current program. And if you're not a parent or have a disability, then you're not eligible at all for Medicaid. If you're an adult, okay. All right, on the next slide. So this is where we get into what does the reinsurance program do? And this is a purely hypothetical example. So if the state were to implement a reinsurance program that was designed to reduce the premiums by 20%, the changes are noted in blue here. The things in black are the things that don't change from the last slide. But what would happen is that top line, $767 per member per month total premium would be reduced by 20%. So that would go down to $614. For those that are eligible for the premium tax credits for the subsidies, their contribution doesn't change at all because it's tied to their income. And for those that don't have any subsidies, they're the ones that would see the reduction in premium. So this only impacts the out-of-pocket costs for consumers that are not eligible for subsidies. So those are shown in blue here. For those that are subsidized, the reduction in premium flows through to a reduction in the federal subsidy. So the consumer's premium doesn't change, but the federal subsidy is reduced by the amount that the reinsurance program reduces the total premium. And so then the way the reinsurance program financing works is that savings in federal subsidies is then passed through to the states to help finance the reinsurance program. So hopefully that makes sense. And then for out-of-pocket costs, it's the same as the prior slide. There's no change in the cost sharing or out-of-pocket costs for beneficiaries as a result of implementation of the reinsurance program.
Yeah, and just because I know there's a lot on this slide, so just to pause for just a moment. You know, and I'm not an actuary, so Julia's doing a fantastic job. So just to be clear, it's that last column on the right that shows consumers' monthly premium for people who are over 400% of the federal poverty level. So when you do a reinsurance program for the consumer, they're pretty much the only ones that are going to feel a reduction in premium or experience a reduction in a premium. Everybody else stays the same. Except for those under 100%, but as Julie explained, it's really unaffordable given the combination of the premium itself and the cost sharing. So really, with respect to what we've seen in other states, those are the folks that are going to benefit the most, is those at the 400% and above of the federal poverty level.
Thanks, Amy. And just from the first slide, just to note that those folks over 400% of the federal poverty level make up about 13% of our uninsured population.
Any questions or comments? Chip Baggett had a question. He's asked, does the federal cost sharing cover the reinsurance cost?
So we're going to talk about that on the next slide.
Okay, go to the next slide. Yeah.
All right, thanks, Chip. This provides some examples of other states that have approved reinsurance programs. And so as I noted on the previous slide, when the premiums are reduced by the reinsurance program for folks that are eligible for federal subsidies, it doesn't reduce their contribution, but it does reduce the subsidy. And so the way these reinsurance programs are financed is that the federal government will then take that savings they get from the reduced subsidies and put it into these state reinsurance programs. And so this slide shows how that pans out for states. And there is a wide variety across the states in terms of how these costs split between the federal and state shares. And there are a number of factors that contribute to that. But you'll see here that in every case, these programs do require some state funding in order to fully fund the program. And that's because not everyone, this program would apply to everyone in the individual market, including those that are purchasing coverage directly through an insurance company. That's that 25% of people that are purchasing coverage off the marketplace. And so there's no federal subsidy that's being reinvested for those folks that are not subsidized because there's no savings to reinvest. So depending on the size of the unsubsidized and subsidized market is one of the drivers for the percent share that states need to kick in for these programs. So you can see here there's a wide variety of costs associated with these programs by state, but on average, based on this analysis, states were bearing about 35% of the program costs on average. Let's see. We also noted Georgia, they recently had a program approved. And so just again, for another data point, you can see that they're estimating that their program will include about $92 million in state funding. There is a publicly available reinsurance program calculator out there from one of the actuarial firms. And so this is, just to give a data point or a point of reference for this program, just wanted to share the results of that. I didn't change any of their default assumptions or anything like that. But that popped out $163 million in terms of what the state cost would be for a hypothetical reinsurance program in North Carolina that would target that 20% reduction, just to match up to the examples that we had before. But if the state were to pursue this, I mean, it could be designed in a number of ways to target different premium reductions based on how much we wanted to put into a program like that. So if we wanted to pursue that more, we'd obviously want to do a more refined estimate and collaborate with the Department of Insurance on that as they have more data. So just to wrap up, the next slide, we're gonna talk about financing of the reinsurance program. But just again, these programs can improve the affordability of coverage for those unsubsidized enrollees. But it's really unclear whether it would be enough to bring uninsured people into the market. All right, this last slide.
I think Tunde might have had a comment. Tunde, go ahead.
Yeah, so Julia, just to make sure I'm thinking about this right.
Yeah.
It's going to cost the state money. It might help those that are unsubsidized, greater than 400% of FPL to the most part. But everybody else, particularly those at the lower FPL levels, it's going to cost more in terms of premiums or out of pocket. I'm just trying to.
So yeah, it will, as you mentioned, it will help reduce premiums for those that are unsubsidized over 400% of the federal poverty level. It does not have any impact on the cost for folks that are subsidized. And for people that are under poverty, it's hard to see how a reinsurance program would bring premiums down enough for them to be able to purchase insurance.
Okay.
I follow up on
the real
that.
benefit, yeah. So the real beneficiaries of this are those over 400% of the federal poverty level.
Yeah, this is Senator Robinson. I wanted to follow up on that too and ask an estimate of how many people would that impact? And the second piece of it, it sounds to me like I'm not sure who benefits here except for that small group of people, or if it's small, like how many people does that impact? And based on percentages of those who are uninsured. Do you know that, Julie?
Yeah, so if we could just scroll back a couple slides, and then we're going to go back to the beginning. So if you could stop at that one, the one with the pie chart.
Yeah, pie chart.
Yeah.
There.
Okay.
So these are the folks that are currently enrolled in the individual market. So this would help the 25% with purchasing coverage outside the marketplace because they don't get any subsidies for that coverage, and the 4% of people who are on the marketplace but paying fully. So those are folks that are currently enrolled that would benefit from the program. If we could scroll back to the uninsured, that one. So because this really supports lowering premiums for those over 400% of FPL, the target uninsured population for this program would be the 13.8% of our uninsured that are in that higher income range.
Okay. And Julie, would they be better off just trying to purchase from the exchange themselves as opposed to, I mean, if you look at the cost for them just to outright purchase, I suppose this helps a little bit, but does this really help them, or is there a comparison?
So, I mean, it helps them to the extent that the premium is low enough to bring them into the market for those that are uninsured. Okay. So, there are a lot of things behind people's decision to purchase insurance, in terms of how they want to spend their money. Depending on how high a priority it is, it may take a lot to induce someone to purchase insurance. But
okay.
Presumably, the idea is that if we lowered or had a reinsurance program, it would help lower costs. But again, it's really targeting those higher income groups. It really doesn't do much for folks under 400% of the federal poverty level.
Julia, can you stay on this slide for a second? This is where I got tripped up because it looks like for everybody below 400%, your average annual cost share goes up. So it's going to cost, if I was at 130% of the FPL today on the marketplace, doesn't this mean that my cost share is going to go up 2.7%?
No, so the cost share is this, sorry, it's a little bit confusing. The 2.7% is the percent of income, and it actually matches what's on the prior slide. So the reinsurance program doesn't change, it doesn't change the cost sharing at all. The out-of-pocket cost sharing, there's no impact on the out-of-pocket
got it.
cost sharing. Yeah, sorry, that's a little confusing.
That's fine. Okay.
Any other questions?
I think there was a question from Erica about, do we have an estimate of the state cost for North Carolina? I think that was your Oliver Wyman.
Yeah.
Yeah.
Yeah. So that was on the next slide. So again, I'm an actuary, so I need to caveat everything to death. So this is from a publicly available tool. I wouldn't use it for budget setting or anything like that. It's just one data point in terms of a high level estimate about what a hypothetical program would cost. So if we wanted to reduce premiums in the individual market by 20%, and the output for this was for 2019, it would have cost North Carolina $163 million to pay for that program. The program in total cost was, I believe it was over $1 billion. So the vast majority of that would be funded through federal pass-through money, but the state would need to kick in the $163 million in this example in order for to fund the program. There's a question, how does this cost compare to the estimate? That's such a great question, and we are going to get there by the end of this presentation.
We're going to get there. Yeah.
All right. Next, if we could go to the next slide, just quickly, this is how states are financing the non-federal share of the program. I don't think we need to go through this in great detail, but just, to take away that there are a number of mechanisms states are using. Some of them are using multiple mechanisms. A number of states are using state general funds, and some assessments or taxes on all or a subset of health insurers. Some of those are assessments are limited to marketplace plans. Some are extending to all health insurance plans. Maine, for example, included assessments on third-party administrators that support self-funded employer plans. So even though this program is targeted to the individual market, the financing of this could, depending on how it's structured, could impact other types of insurance. There was one other that used their premium tax across all insurers, not just health insurers. And then some other states have leveraged provider assessments. So that's just a note on how states have come up with the funds to finance these programs. All right, so we've gotten through reinsurance. I don't know if there are any other questions. Great. All right. So next we're going to move on to association health plans, and we're going to touch really just lightly on this. If you could go to the next slide, because there aren't any direct federal or state costs associated with this policy option. So the association health plans are specific to the employer group market. So for reinsurance, we were talking about the individual market. Now we're talking about the employer group market. And here, when we're talking about this policy option, we're really focused on association health plans that we're talking about allowing small businesses, so those with 50 or fewer employees, to band together to purchase insurance as if they were a large group. So that would put that group of small businesses under the large group rules rather than the small group rules. And that hits on two key areas. One is the coverage requirements for a small group are different than the coverage requirements for a large group. So there are more requirements on the small group market than the large group market. And then the second is how the premiums are developed for those markets. So in the small group market, all small groups across the state are in one single insurance pool. So if you're a small group, you get your premium your premium is set based on the whole market, not the health risk of your employees. For the large group, there's more flexibility in terms of setting rates based on the actual health of employees. So that's the flexibility that small businesses would get under the association health plan arrangements. So what does this do? I mentioned before, there's no direct federal or state costs. This is just changing some of the market dynamics. There is, as we talked about in the last meeting, there's limited evidence of the impact of association health plans on the uninsured. This program, the intention is to create lower cost options for some small businesses. So those with a younger and healthier workforce, if they're able to band together and be treated like a large group, then they're rated based on their healthier, younger workforce dynamics. But it could lead to some adverse impacts for some other small businesses, especially those with the older and less healthy workforce, because if the younger, healthier folks leave the small business market, then that leaves a less healthy and more expensive population in that single risk pool for the small group market. Just a note here that, there is some potential that there could be some indirect impacts on Medicaid or federal marketplace enrollment and costs. So if there's, large take up of association health plans, if we were to move in this direction, then, it could peel some folks off of Medicaid or potentially off of the marketplace. I don't expect that those dynamics would be large, but on the other side, if the existing small group market has some of the younger, healthier workforces peeled away, and those folks are left with higher costs, those businesses could get priced out of the market, and that could lead to higher cost folks moving into Medicaid or the marketplace. So those are just some potential indirect dynamics, but I think the focus here is really on the direct costs. So the real takeaway here is there's no federal or state dollars that are associated with this option, but it does create some dynamics within the small group market that are important to be aware of. All right, so I'm going to pause there. That's all I have on association health plans. I don't know if there are any questions or comments on that.
This is Representative Cunningham, and my question is do we know what an average estimate of individual that's inside of the AHP plans and they're out of pocket, since we were doing it for small businesses, those plans? What do we have an average to see what that actually is?
We could look at differences between the large group and small group markets.
Okay.
And you're asking us about the out-of-pocket costs, like the deductibles and coinsurance.
Right, correct. Because I wanted to see how cost effective it is for those individuals, especially with them losing the essential items that you have to have in the marketplace for your health, the essential coverage for for prevention services, mammograms, those kind of things.
Yeah, I think we can follow up with a side-by-side of the large and small group market rule, what's covered, and then some statistics around what that looks like, if that would be helpful. Representative Cunningham, thank you.
I wanted to comment on that area too, Julie, and say that even though the association health plans focus more on the for-profit businesses, this is one of the areas nonprofits have suffered a lot. And by running one for 45 years, two different ones, I know that the workers tend to be not younger, but they stay with you a long time. They're older. And then the income is so low that at some point I found it very difficult to continue to cover the people who were on my staff, because it was less than 50 people. So it really, unless you're able to get in some kind of plan, and we tried it with United Ways and others, unless you're able to get in something like the state plan, we can't do that. It makes it almost unaffordable for nonprofit businesses to continue to cover their employees, because they tend to be older. It prices them out of the marketplace. It raises the premium, raises the deductible. So it is really a challenge, and we have a lot of nonprofits in the state of North Carolina, but the wages are lower. And this insurance price is it really makes it difficult. So I wanted to include that in this health plan, the association health plans. It's not included, I think, in the thought process, but certainly to make a point of it.
That's helpful context. Thank you. All right, if there aren't any other questions, we're going to move to the next one. And this is something that was brought up in one of the council meetings, this concept of small business tax credits. This is another one we're going to touch on lightly, just because we don't have a clear proposal on what this might look like, but wanted to provide some context for it. If we could go to the next slide. So, and this touches on something that I think Representative Robinson was just talking about some. But if you look at this this chart here, you'll see that health insurance offer rates by employers vary greatly by employer size. So and these are all North Carolina statistics. So smaller employers are much less likely to offer health insurance to their employees than larger employers. I don't think that's a big surprise to folks, but the surprise may be the extent to which some of these small businesses do not offer health insurance. And it's, most likely due to the cost. But as you can see from the table, only about 15% of North Carolina employers with fewer than 10 employees offered health insurance to their employees in 2019, while more than 95% of employers with more than 100 employees offered coverage to their employees. The numbers are actually different and a little bit worse for low-income workers, where the offer rates are actually lower for low-income workers than higher-income workers. And I have those statistics I'll share in a minute. But when you put some of this together and you look at our statistics, so 27% of workers in North Carolina work for a small business, so one with fewer than 50 employees, and more than half of those workers are in a business that don't offer health insurance. So not everyone who's working has access to health insurance, I think is the main takeaway. In North Carolina, by wage, when you look at it by wage, in total, 82% of private sector employees had an offer of insurance. But if you look at the lowest quartile of employees, in terms of wage, only 63% of them had the offer of health insurance by their employer. In addition to offer rates, take-up rates are also different by wage, which makes sense because many of these plans, employer plans, have employee contributions associated with them. And I think I mentioned earlier that on average, those are about $1,500 per year in North Carolina, but they're higher for low-wage workers, closer to $1,800 per year. But among low-wage workers, even those who have an offer of insurance, so the ones that get offered insurance, less than 50% of them are enrolling compared to about 75% of the total population that are enrolling. So there's a discrepancy in terms of offer rates where fewer low-wage workers have an offer of insurance, but then even of those that do have an offer of insurance, their take-up rates are lower, presumably because of the high cost of the employee portion of the premium. So there's kind of two issues embedded there. So small business tax credits, these are programs that we tried to find one that's currently in place in a state and couldn't track one down. If anyone knows of one, that would be great. That would be great. But the small business tax credits, some of these were in place in the early 2000s, but they can be designed in a variety of ways. And we didn't put any cost to this because there are just so many different design elements. But the costs really depend on some of the key design components. So, the first is, would we design a program that's really trying to improve affordability for employers to incentivize them to offer insurance to more of their employees, or to for more of them, more employers to offer insurance to their employees? Or do we do we want a program that also tries to lower the cost for those employees to make it more accessible and affordable for employees to take up the insurance when it's offered to them? So there are multiple dynamics there. Some of the key design elements would be, is there a certain size of business that we would target? Are we targeting businesses that have primarily low wage workers? How big would the tax credit be that we would put in place? It's important to note that small businesses tend to be a lot more cost sensitive than larger businesses. And so in order for a program like this to work and have a meaningful impact on employer offer rates and employee take-up rates, the credits would really have to be quite significant. So that the cost of a program like this could be high. And then another key component is, do you offer this program only to businesses that are newly offering insurance or employees that are newly insured, so that you're really targeting at addressing the uninsured rate? Or do you implement it in a way that's more universal, so any employer that meets that category, if they're under a certain size and have a certain number of low wage workers, that it's more universal and equitable in terms of opening that program up. When you open it up, it costs a lot more, and you're funding programs that are already in place and not necessarily impacting the uninsured rate. So I think there are a lot of complicated dynamics to these types of programs. I think we'd be happy to dig in more if that's something that the council wants to do. So I'll pause and see if there are any questions on that or thoughts.
Yeah, Chip Baggett had a question in the chat. Is there a threshold level of tax credit necessary to get a small business to offer employee insurance? Do other tax credit programs require a certain kind of insurance or limit employee share?
So I think the experience is that the subsidies need to be pretty substantial in order for this to work. I think we can follow up with more. There was a program in the Affordable Care Act. It was a federal tax credit subsidy program for small businesses, and it got pretty low take up, and I believe it subsidized somewhere between 30 and 50% of the cost, but we can follow up with more information on that. I think that, it takes significant subsidies to induce these employers to offer coverage. And I think, the other dynamic just to keep in mind is when we talked about the marketplace coverage on the earlier slide, for employees of a business to be eligible for marketplace subsidies, they have to not have an offer of employer insurance. So I don't know what else to say about that.
Yeah, I think, maybe it's helpful to just follow up maybe with a few additional considerations, looking at kind of what's out there in other states as well. And there was one other comment, and then we probably should keep moving on because we'll have about until 11:20 for this session. There's comments about AHPs and a question around, or a comment around, when the economy is strong, many of the unemployed become employed at some percent of FPL. AHPs could be a nice option for affordable coverage for these individuals. Are there projections based on employment level in the marketplace? And that could be a follow-up also, Julia. I just, we probably don't have that right this moment.
We can follow up on that.
Yeah.
All right.
Any other?
How much time had passed? We have more to get through.
Yes, we have more to get through. So, okay.
Okay. All right. So now we're going to move into Medicaid expansion. And just by way of background, before we jump into the Medicaid expansion details, we just wanted to share a little bit about how North Carolina Medicaid is currently financed. And this shows our breakdown for our program in state fiscal year 2019. So the federal share of North Carolina's program is about 67% for most services and populations in the program. There are some different match rates for different types of expenditures. I'm going to go through this quickly. In total, the feds cover about 64% of our total program expenditures. We have state appropriations that cover 25%, And then the remaining 11% is financed primarily through the hospitals by assessments, intergovernmental transfers, and certified public expenditures. So that's how we're currently financed. We'll go to the next slide. All right, when we develop Medicaid expansion cost projections, there are two main components of those projections. There's a lot that goes into this, but I'm going to try to simplify it. So the first is monthly enrollment projections, and the second are the per person or per capita costs. So we're going to start with our enrollment projections. And we've been relying on analysis done by the Urban Institute to come up with estimates around our expansion population. These are all, none of these reflect the impact of the pandemic, just to note that. But so we're assuming that we would get over 600,000 North Carolina adults enrolled through the Medicaid expansion program. But it would take about 2 years based on experience in other states to ramp up to that full enrollment level. So that's one of our key assumptions. The level of enrollment and the ramp up will depend on policy decisions, such as the timing of when expansion launches, public awareness of the program, the enrollment process, and other factors. So, and there's notes on these, again, because I'm an actuary, I need to put caveats everywhere, but everything here is continuing to evolve. We keep a close eye on what's happening in other states to inform our analyses. All right, next slide. The second key assumption is the per capita cost. And generally per capita costs, not just in Medicaid, are driven by a number of factors, including the average age of the population covered, the health status of the population, the covered benefits, and the cost sharing, and provider reimbursement levels. So those are some of the things that underlie per capita cost estimates and development. Provider reimbursement levels can vary significantly across states, so it's often hard to look at other state costs and apply that to North Carolina or any specific state, because there's a wide variety. For purposes of the estimates in this presentation, we're assuming that the coverage for adults in the expansion group would be the same benefits and cost sharing and provider reimbursement levels as current adults in Medicaid, the non-disabled adults, and that the expansion population would access care through the new managed care system, which we're rolling out here in Medicaid in July. States have some discretion in those design elements, but that's what we're assuming for purposes of these slides here. We did consult with our actuarial consultant, and they have experience with a number of different expansion states. And so we've developed a per member per month cost estimate of the expansion adults of $620 per member per month. And that assumes that population would look like about a 90-10 blend of our current non-disabled adults as our parents and our disabled population. So that's how we came up with that estimate. The federal match rate, again, for most of our Medicaid populations is 67%. So the state kicks in, the state share, non-federal share is about 1/3 of the total cost. For this full Medicaid expansion program, the federal government would contribute 90% of the cost. So that's $558 per month of the $620 monthly cost. And the non-federal share would be $62 per person per month in the Medicaid expansion program. All right, if we could jump to the next slide. I mentioned that we'd come back to the marketplace premiums just to show how things compare. And so one of the dynamics here is if we in North Carolina were to expand Medicaid and do this full expansion up to 138% of the federal poverty level, it would result in some individuals shifting from that subsidized coverage on the marketplace to this Medicaid expansion group. And those are the folks between 100% of the federal poverty level and 138% of the federal poverty level. And so this shows a comparison of the costs between those two programs, just to get an idea of what that looks like. As we noted earlier, the North Carolina marketplace premium was $675 per person per month. That doesn't include the cost sharing, the out-of-pocket costs that folks enrolled in that coverage have and their deductibles and copays. So that the 675 isn't really the true cost of coverage. There's more to it than that, but it's the premium that's for purchasing the insurance. The average federal subsidy, as we noted before, was $606 per person per month. That's on average across all of the subsidized individuals on the marketplace. And because of the subsidies are sliding scale for folks on this in this 100 to 138% FPL, those average subsidies will be higher than the 606. But we don't have a data point there because the federal government doesn't put out that level of detail on the subsidies. Maybe Blue Cross may have some more information that can help inform that. But so when you compare the 606, which is actually probably something higher than the 606, to the federal cost for Medicaid expansion, you'll see that from a federal perspective, it's actually less costly for the feds to cover this group of individuals through Medicaid expansion than through the marketplace. And that's just from a federal perspective. All right. I think we're going to jump to the next slide. There's more information on here that compares the two programs, but I'm going to skip ahead in the interest of time. So I mentioned, there's two main components to developing cost projections, the enrollment and the per capita costs. When you put them all together, this is what we get for our projected Medicaid expansion costs in aggregate. And you can see that, they ramp up over the first 3 years, and that tracks with the enrollment ramp up, and then level off here in year 4, increasing just with our assumed medical trend here. We focus on year 3 just because that's when we're at full ramp up of enrollment. But the projected cost of the program in year 3 here is $5.1 billion. The federal share of 90% amounts to $4.6 billion. And then the remainder, the $500 million, is the non-federal share for Medicaid expansion in North Carolina once we're ramped up to full enrollment. And then just a note here, just tying back to the last slide, is that $4.6 billion in federal share, is not the net increase in the federal expenditures. The net increase is actually lower because we're eliminating some subsidies on the marketplace for those individuals between 100 and 138% of the FPL who are moving. So there's some removal of federal expenditures as a result of that shift. All right, on the next slide. So now we talk about financing options for the 10% non-federal share. So there are a number of ways that that states or North Carolina could fund in our case, we're talking about $500 million in non-federal share for Medicaid expansion. There are some ways that we could do this without using any state general funds. First is that if we assume that the Medicaid expansion group is enrolled in the new Medicaid managed care program, we do have premium taxes, which are actually applied to all insurance companies in North Carolina, and they will also apply to the new managed care organizations. And so the increase in Medicaid managed care enrollment would basically automatically generate increases in the state's premium tax revenue. And so that's one way that could be used to offset some of the 10% $500 million non-federal share for Medicaid expansion. Also, as mentioned earlier, right now in our current Medicaid program, about 8% of our expenditures are financed by the hospitals. That's another mechanism that could be explored to leverage for offsetting some of the costs of some of the non-federal share for Medicaid expansion. We could explore assessments on other provider classes. Those would be new to North Carolina Medicaid. We do currently assess nursing homes, although we wouldn't really expect them to benefit much from Medicaid expansion, but there are other provider groups that may. And then we'll get into more detail on this, but Medicaid expansion would also generate some savings and offsets in current state-funded programs. And that's another area where we could look to leverage savings to offset the non-federal share. All right. This slide, again, just provides some examples of some other states' financing of their Medicaid expansion programs. You can see a number of states that are leveraging various assessments and fees for their programs. Some of them are fully financing their non-federal share through these mechanisms without touching on any state general funds. All right. We mentioned offsets to current programs. The numbers on this slide reflect when we get to full ramp up. So this is really in year 3 after we've gotten to our full enrollment, just to note that. The first one is, as Deputy Secretary Cody Kinsley mentioned in our last meeting, we have a number of state-funded programs that fund mental health and substance use services for uninsured and underinsured individuals in North Carolina. Of that expenditure, we're estimating that about $56 million of that spend is on individuals who would be eligible for Medicaid expansion. So, you know, one of the things to note here on the state-funded mental health expenditures is that we may actually need to maintain some of those expenditures in order to continue to draw down federal mental health block grants. At least a portion of that may need to be retained. It wouldn't all necessarily translate to savings, but it would, if we were to expand Medicaid, it would free up those limited dollars in the state-funded mental health system to serve more people in that program. So that's an important dynamic. We also estimate, oh, go ahead.
Just a time check. You have about 8 to 10 minutes, just so you know.
Okay, all right, we'll get through it. We also estimate that some of our current Medicaid program enrollees could shift to expansion, and that would increase the federal share that's available for those folks. And those are more of our limited coverage programs for pregnant women, as we've talked about. And so that generates some savings within our current program. We talked about the premium tax revenue. We're estimating that the net increase in premium tax revenue would be about $70 million, which offsets about 14% of the $500 million non-federal share. And then some offsets in the Department of Public Safety. They use state dollars to fund healthcare services for inmates, and inmates that receive inpatient care can get Medicaid federal match. And so this would increase the number of inmates that with that option available, and at the higher 90% match rate. So that also generates some savings within existing state-funded programs. All right, I'm going to do a quick pause before we get to the last item.
Yeah, and there've been a lot of questions here. So, you know, and I think it's worth spending an additional 5 or 10 minutes just to make sure we get everybody's questions answered. So, Julia, I don't know if it helps to go to the comparison slide, because there's questions that span across a couple of different concepts. But there's a couple specifically around, let's add, Senator Bergen just asked, what are the projected actuarial savings from the implementation of Medicaid managed care on July 15th by year for the next 5 years?
I think we'll need to follow up with that one.
Okay, we'll follow up with that one. Chip Baghead, what are the premium reductions from other states attributed to from the reduction in uncompensated care?
We may need to follow up on that one, and Chip, I may need a little more context on that one.
Chip, do you want to just chime in and add any more context now?
Sure, I'm just saying that if we can stop having to pay for uncompensated care through increased employer marketplace insurance, then with that reduction going, I'm trying to figure out what that reduction would be, because that might also then incentivize more people to do association health plans, MEWAs, employer-based insurance in general.
Yeah.
Yeah, I think we can follow up on that, those potential cost shifting dynamics.
Yeah, and Tunde had a response. Go ahead.
Yeah, I just put it in the chat that based on the national data I've seen, I think Kaiser and Health Affairs, I think did some studies. I have them somewhere. I can provide them later to Julia. On average, marketplace premiums are 7 to 12% lower in states that have expanded Medicaid. So you get the lift on Medicaid expansion, right, in terms of coverage of more individuals. And then you also get the lift on the ACA marketplace, side of the ledger, because the premiums are lower.
Yeah, that's a really important point. Thank you. All right. Why don't we keep going? So just really quickly, we looked at, next slide, we looked at partial Medicaid expansion. So this is something that a number of states have tried to explore with the federal government. And this would be expanding Medicaid up to 100% of the federal poverty level, and then leaving the folks that are getting marketplace subsidies alone in the marketplace. And what states have asked for is to get the enhanced 90% match on that partial expansion program. And both in the Trump and Obama administrations, those requests were rejected. So for purposes of this presentation, we're assuming that partial expansion would only be eligible for the regular 67% federal match. And the dynamics of that basically is, through partial expansion, we would only cover about half of what we expected in full expansion in terms of number of people that would be covered. The cost is lower because we have lower people in total, but the non-federal share, because we don't get that 90% match, we only get the 67% match for that program, is $900 million, which is more than the $500 million for full expansion. So it would cost the state more to do partial expansion than full expansion and only cover half the people.
Now, I'll just chime in here. We don't know exactly what the new Biden administration is going to do to incentivize states to expand Medicaid. I think, we will just have to wait and see whether they consider. Other states have certainly asked for enhanced match up to 100%. As Julie said, no one's gotten that approval yet. I'm sure there will be requests in the future. So just something that we have to just put a pin in, because we really don't know enough yet about what the new administration may or may not do. So I note that.
The other two that are on here, I won't go into great detail, but one is in the current program, because of our 42% income eligibility for parents and that we don't cover childless adults in Medicaid. If a parent loses their child to the foster care system, a child enters the foster care system, the parent is no longer considered a parent in the eyes of the Medicaid program. And so they no longer meet the categorical eligibility for Medicaid and lose their Medicaid coverage. And as we talked about before in the prior meeting, a number of them are dealing with substance use issues. And so they'd be getting their coverage terminated, or they are getting their coverage terminated at the time that they might need it most. And so this proposal would extend coverage to parents. If we were to do Medicaid expansion, it would really negate the need for this type of extension of coverage, because these parents would be covered even if they were not considered parents in the eyes of Medicaid. And then the last one here is coverage for women to extend that coverage 12 months after birth of their child. We estimate that could impact about a little over 30,000 women a year in Medicaid. And you can see the costs that are here. So why don't we go to the summary slide just to roll these up. All right, so we promised we would put this all in one slide so folks would have it as a takeaway. And so what we have here is, you can see the target population for each of these programs. We added the impact on affordability of private coverage, and then the federal share and the non-federal share of the cost, and whether there's an option to finance the non-federal share without state general funds. And so I'm not sure that we need to go through this in detail. I think we talked about some of the dynamics between full Medicaid expansion and partial Medicaid expansion. For the individual market reinsurance program, again, that's a hypothetical program, but if you line up the costs and it's unclear that we would be having a big impact on the uninsured. That's just something that I would call out. I don't know, Hammy, if you have anything else you want to add, or we can open it up for questions.
Yeah, I think there's been such a great discussion going on in the chat. I think we should probably turn to those questions now. So I'll read a few, but people should just chime in if because it's quite a long chat. So Senator Bergen had a question about some of the subgroups you just went through, Julia, partial Medicaid expansion, pregnant women, and parents of foster children, and whether any states have had waivers for subgroups approved. And I can comment, and you please confirm, for the partial expansion, definitely not. There are states that have requested up to 100%. They've not. They've gotten it like Utah before they moved to their full expansion, but it wasn't with enhanced match. There's a number of states that have requested postpartum coverage for 12 months, but they hadn't gotten that approved under the Trump administration. I think there's interest in the new administration, and there's also interest at the congressional level, Capitol Hill, of doing something on that point. And I don't know about the foster children. So Julia, go ahead. Anything on
that? We'll have to follow up. I think other states have done that, but it's been a little while since I've looked at the other state analysis. So we can follow up on that.
Okay. And we will, there's another comment about there was 100 of the IHS population and the 100% match. And would the federal share be 100% for American Indians receiving care at an IHS or a tribal facility? I think that was earlier during your Medicaid expansion presentation from Casey Cooper.
My understanding is that the 100% match would apply.
Okay.
For American Indians. That's the current how it's currently treated in the current Medicaid program, and that's how they would be treated under expansion as well in terms of those costs.
Okay. And people, please, council members, please chime in because I want to be sure we're getting to everyone's questions. Chip, you have a couple. Do you want to just chime in now? I'm happy to read them also.
I guess my biggest question, and just on this last slide, because I like how this is summed up here, but on the 4 categories where you have unlikely, are those unlikely because they are blocked by law, or because it would require a new waiver, or some other limitation?
Yeah, I think the unlikely there is because those don't necessarily generate new revenue or savings the way that the say Medicaid expansion, the full Medicaid expansion would. We could leverage, again, we could leverage, hypothetically, if we leverage hospital assessments for Medicaid expansion, one of the reasons that works is because the higher federal match, and so the share of the non-federal share is lower as a percent of the population. So the math, I can follow up with a more articulate way to describe that. But I think for the 3 at the bottom, at least, we assume that we would be leveraging a similar financing to what we do in the current Medicaid program, because it's really, the math is like our current Medicaid program. And right now in the current Medicaid program, 25% of it is financed through state general funds. So we'd have to come up with some new mechanism to pay for it when the state share math is just like our current program.
But Julie, if I could jump in, it's Mandy. Sorry, I haven't wanted to jump in because it's really good discussion. Chip, I do think that there are some pieces on here where we would have to get approval from the federal government in the way we would structure the financing. And it is unclear. I think part of the unlikely is the uncertainty of what we could get approved at the federal level. So I think we want to acknowledge that as well.
Other questions and comments? This has been a really good discussion.
This is Representative Cunningham. I thought the number that was given for the federal drawdown per person per capita was kind of low compared to some of the other states. Is that significant, that $600 and something? I can't remember the exact amount, but it was $600 and maybe $58 or something.
The $620 per person.
Yeah. I'm trying to see how they got there, because if we look at other states, is some evidence that they're actually drawing down more than what we would draw down. And I was trying to figure out what that was based on.
So it's built on our current, the cost of our current Medicaid adult population. So we assume that they're more costly on average than our current adult population that's covered in Medicaid, that they look more like a blend of a 90% of our parent population and 10% of our disabled adult population. So but you know, as I mentioned, states have a variety of different programs, especially when it comes to the provider reimbursement level. So I'd be interested to see what statistics you're looking at, and then maybe we can provide some context in terms of differences. I think that would be helpful.
Okay, follow up. I was looking at what the Kaiser had put out and looked at what Tennessee's drawdown is and some of the other states' drawdown is. If you draw down per person, not that our people in North Carolina compared to another state based on what the federal pays and what the state pays for its Medicaid, actually the drawdown was higher for the states that expanded. And for the states that did not, then we didn't get a significant drawdown from the federal, but it is higher. And I was trying to figure out, why is it ours so low when you start looking at other states and their drawdown? And
So,
that's with Medicaid.
Yeah, so the federal, right. So sorry, maybe I was answering the wrong question. The federal, are you talking about the federal match rate, Representative Cunningham? Okay. So yeah, our federal match rate, which is 67% right now on most of our populations, for the expansion population, it would be 90. So expansion states would typically have a higher blend of federal match rates when you put those together. But the basic, our 67% match rate is state specific. The 90% match rate is set for all states that expand Medicaid. And that the regular match rate varies based on state demographics and other characteristics. So those can range significantly across states.
Other comments, questions? I think there's a number of follow-ups that we will send out to the council, which I know Julia and the team will pull together. A couple of things just to remind everybody, there was a request for the data impact of the cost of AHPs, and there was going to be a comparison of small and large group markets. I think there was a question around projections around employment level and marketplace and how that can impact AHPs. That's another follow-up. And then there were some, I think, additional information needed for the tax credit piece. And you know what other tax credit programs have with respect to requirements for certain kinds of insurance and limits on employee share. There was a question, and then Senator Bergen had a question around the foster parents and whether other states have gotten approval for that. So that's definitely a follow-up. And then the projected actuarial savings for the Medicaid managed care program. So a couple of things there. There was a question earlier about deductibles for reinsurance programs, or actually for those on the marketplace, and how that can be impacted by reinsurance, which we didn't get to. I don't know, Julie, if you want to just comment on anything with respect to deductibles.
The reinsurance program would not have an impact on deductible levels.
So whatever deductibles could exist in a particular coverage package for someone on the marketplace would remain the same. Reinsurance wouldn't have an impact. Okay. Okay. Was there anything else on that, on what I just rattled off? Is there anything else, other requests that we should be following up on? If so, you can always email us afterwards or just put it in the chat. So anything else for the moment? Okay. Well, thank you, Julia. That was a really excellent presentation, a lot of information. Oh, wait, Steve Lawler had one more comment. Is it fair to say that other states have used different strategies and tools to draw down additional federal funds?
Yeah, this is Steve. Yeah, I think part of the analysis is just kind of casting a big net to see what are all the tools and levers that other states have used to be able to kind of increase their federal share, because that when you do that, that does advantage North Carolina as we look at, what is it going to take for us to expand coverage?
Okay. Want to comment on that, Julia?
Yeah, I mean, that's something we work to do every day at Medicaid, is to be good stewards, especially of state dollars, and find those ways that we can maximize our financing. So we can follow up on that to get more detail around what you're looking for.
Yep. Okay. Thank you, everybody, for such a great discussion, and thank you to Julia for the presentation. So following this, we're going to send out the slides, which has the summary slide. We also will just be the collector of some of these data points and follow up and make sure we get it back out to council members pretty quickly. And of course, any other questions that you have, please just put in the chat or follow up. Elaine Sheehan, you have her email. You can always send a question that way too. So. Okay, we're going to keep going because we have to get to our breakout rooms and get you all discussing all of the different pieces about the guiding principles. But before I do that, I just wanted to talk briefly about the survey results. So thank you for everyone who submitted their survey results. We got a few more since our last meeting. So as we walk into thinking about guiding principles, we really wanted to take the information you all provided to us with respect to what's your priority areas for expanding coverage for people in North Carolina. And really, with the additional responses, it's very similar to what I presented the last meeting in terms of what people wrote in. There was largest number of responses was on the left, which was increased coverage and access for all of these different populations that we've been talking about: children, mothers and pregnant women, parents of foster children, rural areas, substance use disorder and mental health services, the uninsured and underinsured, veterans, and essential workers. And then across on the right, you see all of the other concepts, many of which Julia touched on today, which included association health plans, closing the coverage gap, Medicaid expansion, state innovation waivers, which is the reinsurance piece. And then there are a couple of other things that came up in your responses about reducing disparities in coverage, provider solvency, support for safety net providers, access to quality care, telehealth, access and coverage. We talked about the tax credits for small businesses today, and we talked about the state subsidies for purchasing exchange plan coverage. So just wanted to make sure that we fed that back to you because it was really helpful for us to get that data from you all. Okay, next slide, please. Great. So today, our next goal is to get you into small groups to talk about the draft guiding principles. You should have received a draft earlier this week, but just to refresh, because I know everybody is very busy and probably didn't have time to necessarily look at all of it in great detail. This is just a snapshot of what was in that document. And really, this is just an initial draft. This is not final in any way, shape, or form. This is for you to react to in your discussion groups, to really talk about whether these are the right things to have on the page, whether there's things missing, whether things need to be tweaked, et cetera. And just thought I would take a moment to go through what they are. And it's, again, the goal of the council is to address coverage. So they're really grounded in that piece. And it's really informed by all of the survey responses and really the great conversations we've had over the last meetings. So the first pillar was access to coverage. And I won't read the whole slide to you, but just there was clearly an interest in thinking about a lot of different ideas around coverage. And so that's what's reflected here. And that's what you all can talk about in your breakout groups. There's something on affordability. That's something that certainly has come up throughout these meetings about thinking about how to make coverage more affordable for different people in North Carolina. Health system sustainability, that's certainly also come up in the conversations of how can the healthcare system in North Carolina be fiscally sustainable for consumers, providers, et cetera. Efficient use of taxpayer dollars. So both with respect to all the different ideas that we've been talking about, what can be the best way to be efficient with those dollars. Supporting the business community. The last meeting we talked a lot about this. Especially small businesses who are struggling to provide affordable health insurance to their employees during the COVID epidemic and beyond. In the last meeting, we also talked a lot about behavioral health services and expanding access to and coverage of those services. So that's why we included them on this list. Strengthening our rural communities. So this was also a topic I know is near and dear to many of your hearts. How do we really improve coverage and the healthcare system in North Carolina in those rural areas? So making sure that any strategies we talk about address that. Reducing disparities, taken straight from your survey responses of how to prioritize reducing disparities in geography and by race and ethnicity. And then there was additional considerations for access where we just included some of the other ideas that had come up in conversation and in the survey responses, which included telehealth, network adequacy, provider incentive programs, and preventive services. Next slide, please. So what we're going to do now is you didn't have to memorize all of that. We're gonna show those the document to you when you go into your breakout room if you don't happen not to have it handy. All of the breakout rooms will be facilitated by Duke Margolis staff. We are your neutral facilitators. We will be taking notes, just making sure that we stay on time. And so you all don't have to take notes, but as we go into the sessions, just put your thinking caps on and be ready to kind of just dig in a little bit with your fellow council members. And we will do all the hard work of typing it up and making sure whatever you say gets reflected in the document, which we will be showing to you on a shared screen throughout the breakout session. If for whatever reason you should automatically go to your breakout session as soon as we say it's time, if for whatever reason you don't, our handy expert Luke will be standing by, making sure you get to that right session, but his email is there. If you have any technical issues, just reach out to him. One thing, just so you can start thinking about this, we are, after we go into our breakout sessions for about 30 minutes or so, we're going to come back together as a group for the last part of the council meeting so everyone can hear from one another about what happened in those breakout sessions. And we're going to ask one of you council members to be the reporter. Again, the Duke Margolis staff will type everything up and we'll put it up on the screen so you don't have to memorize it all. But if one of you wanted to volunteer, that would be great. With respect to the types of questions we're going to ask, we'll walk through that. But really, it's very like, you know, what are your reactions to the straw man? Are there things that are missing? Are there things that need to be prioritized? Or are there things that we really need to tweak? So that's going to be the nature of the conversation. And we really look forward to it. So before we break, does anyone have any questions for the larger group?
I have a question, just to make sure that I'm thinking about this, so we're all on the same page. So is it fair to say that our going in premise or underlying premise is that access to affordable healthcare coverage is foundational? And whatever solutions we come up with should, to the extent possible, address some of the things you mentioned: efficient use of taxpayers' dollars, relief for employer groups, particularly small businesses, sustainability of the health system, expansion of behavioral health services, mental health parity, and then trying to remember off the top of my head, last but not the least, maybe it must address all geographies, rural, urban, suburban, and populations, socioeconomic, racial, ethnic, and so on, so that we make sure that we're factoring in health disparities into the equation. So is that how to think about it, foundational? And then whatever the solution, okay.
Yeah, thank you for that clarification. Yeah, these are their principles. They're, you know, your kind of what you all think as a group should be, what you want for North Carolina at this like bigger picture level, and then the specific strategies flow under that. And so the strategies that you're not tasked with, you know, putting down on paper, but that could come afterwards, would address, you know, affordability, would make sure you're addressing rural populations, would make sure that there's going to be opportunity for small businesses to have affordable coverage for their employees. That's precisely it. So thank you for that comment / question. Does that make sense to everybody? Anyone else have any comments or questions before we break? Okay. All right. Well, we'll see you back here in about half an hour. And welcome to your breakout rooms.
Right. I think we're all back. I appreciate everyone taking the time for those in-depth discussions and for being with us throughout the whole set of discussions today. A lot of areas where we need to get some more information and follow up, but also a lot of good topics and potential common ground to help inform the principals. So we'd like to hear back from the groups now. And Amy, I'm not sure which group you'd like to start with, but hopefully I can get some good report outs on what each of our groups has been up to.
Great. I might start with the group that Elaine Sheehan was facilitating. Elaine, where are you?
So Jean, you can go ahead.
Okay.
Well, first of all, I had a fantastic group, so I just want to start off by saying that. I think that the couple of things that we came up with, we wanted to put a finer point on a couple of the principles. One was this idea of rural, making sure there's rural coverage. And so that we would sort of highlight that. And we all know that once a rural hospital closes, really the impact in that community is hard to recover from. So making sure that that's protected. Also, the disparities of care and coverage. And what the comment was is that we're seeing a lot of disparities in COVID, but really that which just magnified what was already there. And so that once the vaccine gets in circulation, let us not forget that it was still always an underlying issue. So the disparities and the rural coverage came up as something we talked about. And then part of that is also healthcare system sustainability. We know that health systems frontline workers have been really hit now. So as we go forward and expand, let's make sure that the health systems have enough resources to continue to serve the community. Then we talked about this idea of let's make sure part of the principle should be maximize coverage. Don't let a perfect be the enemy of the good kind of thing, and that there may be a pluralistic approach to making sure that happens. And so that was something we spent some time talking about. Then we discussed this idea of let's be transformative, let's be bold, and let's pick one or two things that we think we can really make a difference in. So we talked about behavioral health as we did last time. So how do we really lean into that as part of expanding coverage? And then telehealth, obviously that's really served us well during this period, but even in these conversations, some of the internet was unstable. And so as we look at telehealth, the discussion was we really have to invest in the infrastructure to support that, including in rural areas. And then we know that there's a digital divide that we've seen. So really the infrastructure support that's required to make sure that we are transformative in telehealth was what we discussed. And then part of that conversation was we sometimes, there's a lot of new technology that's coming out there. So let's make sure as we modernize our infrastructure for telehealth, we're paying attention to what's to the most modern approaches to that. And then the couple other things was, healthcare is a very complex process. So there should be a thought that we should of simplification. So whatever that means, and that would probably cut across all of the principles. And then there was a conversation around sometimes it's not just about expansion of coverage, but really expansion of accessibilities. We have in many areas of the state not enough primary care. That could be through telehealth, but also that could be by supporting really physical presences in some of the underserved areas that in order to not just expand coverage, but make sure people have the right access to local coverage. So I think that was sort of the summary of our discussion.
Gene, that's great. Really appreciate the emphasis on, as you said, not just coverage, but coverage that's meaningful and it's done as efficiently as possible with some clear goals for having an impact. Other members of the group want to add to that? Well, great summary. So thanks very much. And Amy, next.
Yeah, Rebecca Whitaker's group. Who was the spokesperson in group 2?
That's me.
Chip. Okay.
So we had a great conversation about each one of these principles proposed and talked about really many of them being results that we wanted to see, maybe more so than principles. And if we really focus back on the coverage conversation that we've all been charged with, we felt like the top two things, access and affordability, were the two biggest drivers. And without those two pieces coming together and maybe even further defining those, exactly what does access look like, to some of the points Jean was just making, what does affordability really look like, so that we have a common definition around affordability. Without those two things, then people lack the golden ticket to get care in the first place. And without that ticket, everything else kind of goes by the wayside. So that was our focus. Even there were strong points around the use of telehealth throughout the principles here. There were emphasis on residual benefits of all these different things, but it really just kept kind of coming back to, what does access really look like, increased access, and what does affordability really look like?
Thanks, Chip. Other members of the group, or maybe if you could expand a little bit on, definitely get the importance of understanding what access and affordability would look like, but was the thought to try to make that a little bit more concrete, or to give some more examples to go along with the general principle?
This is Representative Cunningham. I think we wanted to have some things in concrete as far as looking at access to coverage and affordability, that they kind of go together, that they're not separate. If you have one and don't have the other one, then you're still not accessing a healthcare system and quality healthcare at that. And the other things that we kind of looked at, like the telehealth, the behavioral health, the rural and the healthcare disparities, all come up under those same two titles: access to coverage and affordability of coverage. It all ties back. So I think that was what we kind of focused on, because we still knew that we had these other things such as rural healthcare disparities, racial healthcare disparities. We have behavioral health. We still need to define what true parity is for behavioral health, because from what we know now is that even though we put statute in place, even at the federal level and the state level, we still are not accomplishing parity. And so how do we do that? But it still falls up under the top two: access to coverage and affordability of coverage.
Thank you. Any other comments from the group? All right, thank you all very much. And next, Amy?
Maybe we can go to Will Blesser's group. Will, who was your spokesperson?
That would be Dr. McNeil Trice, and I'm just getting my document up here.
Okay.
Thank you. Yes, I was voted unanimously to be spokesperson.
Can you see this?
She's a YouTube sensation, so why wouldn't she be?
Oh my gosh. Oh no.
Can you see this okay?
Now it's kind of skewed to the side. Can you bring it over? And is
Yeah,
that the top of what we talked about?
Yeah, these are the so I organized it into sort of 5 main bullets, and I can scroll with you.
All right.
Still
Yep, I can see it. Thanks, William. So our group talked, we had a really great discussion, and I think covered quite a bit during our time together. I think one of the foundational principles that we talked about was some ideas to actually consolidate some of the guiding principles and focus, feeling as though it's likely easier and we can be more productive when you focus on 5 guiding principles or a fewer versus 10. And several of them actually are very relatable, echoing what was said before. Having access to coverage and affordable coverage have to go hand in hand. So thinking about how Medicaid transition really does affect these guiding principles. And we talked about being able to prioritize what issues, being deliberate about what we should prioritize as things are not getting necessarily better, and wanting to implement certain actionable items sooner than later. With regards to access to coverage, we feel as though that is fundamental, and I can even see access to affordable coverage, and really considering what are the important steps and steps needed for Medicaid expansion. that we owe it to our constituents and those we serve to actually look into options in a scalable way to address the access and covered issue. We feel as closing the gap of the uninsured is absolutely fundamental, especially for building strong rural communities and a broader economy, to make sure that we focus on that. All populations, regardless of their socioeconomic status, racial identity, ethnicity, but also not wanting to minimize and ensure we're not minimizing our patients and families and children who are in rural settings. The economic activity is vital there, and many are leaving those areas for more urban communities, and healthcare is definitely vital to that. It has to involve efficient use of taxpayer dollars, and important to ensure that the expansion doesn't come at the expense to other covered populations. And we wanted to have opportunities to ensure that with regards to what we do, that we dive deeper into a cost benefit analysis of any and all options that would be considered. We feel that any options pushed forward have to have sustainability of healthcare systems. Federal dollars are only drawn down when services are received, so we need to focus on what services can be provided through expanded coverage. I brought up the issue of workforce development. There are many of us who are educators or have been preceptors, and that is critical, and we see firsthand daily physicians who have been trained and want to go into rural settings, and those jobs are not there. Many of them are involved in federally funded loan repayment programs, and finding FQHCs, especially those that involve pediatric care, is incredibly hard to do in certain areas of North Carolina. And so there are workforces who are interested in going there, but are unable to find those jobs. And are there ways that we as North Carolina can actually strengthen our pipeline programs, some of which were in existence before and are not, to actually have a pipeline of providers to return to these areas, many of whom grew up there, and actually provide incentives for them to come to the areas, to be a workforce, to provide access to not only affordable healthcare, but exceptional healthcare. And then underscoring all of what we talked about is the crisis that we are seeing in mental and behavioral health in all settings. We believe that this should be a focus and underscored in all that we do, and not just a focus with regards to access to appropriate mental and behavioral health services, but also the parity in those services. Many of our healthcare systems are beyond capacity, and those providers who are in the community don't have the equipment or the resources to provide the need that is needed in the community. And then last but not least, we've realized that the COVID pandemic has brought this into play. Telehealth has been exceptionally vital in our provision of care, especially to areas that are a bit more isolated, but we need to support the foundational services that are needed to provide access to telehealth, to appropriate telehealth services, not only for our providers, but for our patients and families who depend on them. I had several amazing members in my group, so let me know if I missed anything. I tried to get it all down. Thank you, William, for taking those notes.
Thank you, Dr. Trice. Great overview, and you all were definitely had a substantive conversation. Other comments from the group? I'm seeing some common themes here around focus on affordability and efficiency with the taxpayer dollars, and making sure we're having an impact in critical areas like telehealth, behavioral health, and the rural disparities and racial disparities in the state. Great. Okay, Hammy, next.
Okay, so the next is group 4, and I facilitate that. And I have to say we were mid-sentence when we got switched to the main session, so we didn't appoint a person. So I will go through the comments, but I really want the group to chime in because it was a really excellent discussion. So let me just share my screen. Okay, let's see. Okay. So at the top, with respect to access to coverage, there was a conversation around making sure to think about coverage as comprehensive, and really maybe being more specific about covering essential benefits or covering all essential health services so that people really have full access to all of the things they need, which would include behavioral health and some of the other things that we list below. We also had a conversation around, certain approaches that could be really beneficial for North Carolina. For example, association health plans could really address, 200 to 250,000 uninsured in North Carolina, and that's really important to make sure that is reflected in what we think about as we come together on these guiding principles. And I think there was a broader conversation. This is really, Mark, maybe for talking about what we're going to do in the next meeting, but really wanted to have more conversation around what are real options, which is not necessarily reflected in the guiding principles, but more generally that North Carolina can be thinking about with respect to, waivers in other states, that may look at partial options, that may look more in detail around reinsurance and AHPs, and what is really opportunities for North Carolina to think about these pieces, as well as telehealth in a more holistic way and in a more detailed way than perhaps what we've done in the first couple of meetings. So definitely wanting to spend more time in that fourth meeting to address those really important components. We're really lucky to have Vivian in our group, who could talk a little bit about her experience as a small business owner. And she talked about, a note from her was, one of the things is really making coverage easy to access and making it easier for people to be able to have that access to coverage. And she wants to make sure that, in whatever strategies we think about, the rural piece doesn't fall by the wayside. We also had the pastor, who of course lives in a rural community, had very eloquent things to say about what he sees every day with the population. And, for him, it really feels like he reflected that people really needed to have access to coverage. And I want you all to chime in. So I'm just summarizing all of the great comments you all provided. We talked a little bit about the business community and how we need to make sure that we talk about both for-profit and nonprofit businesses. We shouldn't just focus on for-profit, but there's also a number of nonprofits where it is really difficult to offer insurance. And so making sure in whatever strategy we think about that it addresses that piece. And then just back to the rural, I forgot this piece, is also not as coverage as part of ensuring access. Their access to care itself is really challenging in rural areas, and telehealth is one piece, but making sure that we think more holistically about access. And then Cassandra made sure to point out that essential workers are really important in all of this. And so thinking about how calling out essential workers as priority for coverage during the pandemic, but also following the pandemic, and really reflecting kind of what we've seen really exacerbated by COVID-19 and what we can build on following it. So hopefully I captured everything, but really want to make sure that my members of the group, please chime in if there's other things that you want to share from our discussion. Anything I missed? Senator Robinson, anything? I know you were very active. Anything to add?
Only one thing maybe. I think you did great. And I just think that we need to keep in mind in terms of who is covered under Medicaid, that it's not what that breakdown of that chart you need to send out again in terms of what the Medicaid population is. Because I heard the pastor from Reverend Brigman talk about the people that he sees who are have 3 and 4 jobs, but are out of that employment age. They're over 40 and can't get insurance or either in Medicaid, or they're working 3 or 4 jobs. So I thought that those comments were very critical. Reverend Brigman, I don't know if you wanted to share that in terms of the rural areas and the lack of access that you're dealing with. I thought that was very important.
Yes, ma'am. There's a lot of people in Richmond County, a lot of small businesses. So there's a lot of people that have to work several jobs. They might only work 12 to 20 hours a week. And they have to work around a schedule such as that, because there's just not, either the businesses don't want to pay them full time, maybe. That's what I've been told, that some businesses would rather work all part-time employees to keep their benefits and all of that down. Mm-hmm. So I know several that work 3 jobs, and they range in age from 18 all the way up to into their 60s. you know, and it's heartbreaking that you have women, girls that are 20, 25 years old, and they're having to run from place to place and have to find babysitters to work around that schedule, and pay babysitters, because when you don't have a full-time standard job working 9 to 5, it's hard to get a health care for that. So, you know, it just adds more stress and anxiety on them to ensure that their children are cared for. You know, so there's just a lot of situations like that in the rural areas when you don't have the textiles no more, you don't have the industry that we once had here. It's all gone.
Anyone else from the group want to comment? Thank you for sharing that. Senator Bergen, anything you want to share? I don't want to put you on the spot, but.
Oh, I know everybody's time's getting late here. I'll wait. Thank you.
Okay. All right. Great. Next group is Kirk's group. So I don't know who the spokesperson was for that.
That's Merit. So I'm going to go ahead and share my screen.
Okay.
Is that working? Here we go. All right.
Apologies. Can you hear me? So I'll try and be efficient, but I do want to say that we had an excellent group and a really good discussion. In terms of, we did a combination of maybe come up with some new ideas or potentially new ideas and expanding on current ideas. One of the newer points that could be folded in is a focus on system and program integrity. So the idea was right person, right care, right time, sort of thing. And then another was to really emphasize that this is really a focus on the health of North Carolina. And so we're talking about coverage and health care, but really it's a focus on health. I would echo some of the other groups about identifying that it was challenging to define what affordable meant, but that was important. And there was also a discussion about the fact that the healthcare system in North Carolina is really an ecosystem of a lot of intertwining parts. So sustainability really contemplates investing in that whole ecosystem. In terms of the strengthening point, we talked about expanding provider capacity, as well as the fact that we really want to support and strengthen all providers, all different types of providers. And two examples that were raised were dental and mental health. So that was an area of importance. And then I think a point was made about focusing on lowering the cost of care. The comment was made that there's a line between improving coverage that improves access and just simply improving access. And so that was a question about, you know, focusing on cost of care. We also emphasized the importance of telehealth and broadband access. And then another point that was newer was the idea of optimizing system infrastructure and function. So considering the presentation we heard earlier, which buttons do you need to push to really optimize the function of the program? Social determinants of health was raised as an issue, and we have a question about would that fold into an existing bullet point, or is that one of the additional points at the end? And then I thought that what was very interesting was, you know, Kirk asked us to prioritize these, and there was some really good discussion. And what we sort of came to was instead of prioritizing so that something's really important and something's maybe not as important, maybe focusing more on foundational concepts. What are the foundational concepts from which a lot of these other concepts will be supported and be able to happen? So I thought that was a sort of a building block approach. You know, we thought that was a nice way to think about organizing the list. And again, I like the other presenters. If somebody else in the group wants to chime in, please do.
Thanks, Merritt. Other comments from the group? Great discussion. Hammy, anything to add?
No, and I just have to thank all of you for really the thoughtful, engaged conversations that you had across all of these groups. We're going to take all of this back and do our best to try to combine everything into a document that will no doubtly be longer, and then share it back out with you so that you can take a look at that before we meet again on the 22nd. So, your input is very valued. And I think at the meeting on the 22nd, we will really spend more time going through all these different ideas, in addition to what I mentioned about talking about some other options in more detail, which is definitely something that some folks are interested in. So.
Yeah, well, we definitely have a lot to follow up on. Thanks to all of your input today. Really appreciate everybody sticking with this and working together so constructively. Definitely some, in the first part of the day, some items that we heard about that we want to get some more information on about how it can impact these principles, areas like association health plans and the reinsurance programs. And we are, as Hammy said, going to do some real work on the principles based on your input. Appreciate the emphasis on access to coverage and affordability of care, but especially the ideas that you all described on making sure that we're going in a direction that's going to have meaningful impact. Telehealth, behavioral health, rural disparities and racial disparities, and recognizing that it's not just about access and it's not just access is not just about coverage, but the importance of care provider availability, the importance of supporting technology infrastructure like telehealth, and the importance of doing this in a way that reflects efficient use of taxpayer dollars and sustainability. We'll also try to recognize, the governor mentioned at the outset, that COVID has exacerbated a number of these underlying issues. So it's very timely to address these steps, and that any kind of response clearly is going to be multifactorial. So we'll consider include the partial expansion options, as many of you suggested, association health plans, et cetera, that might be able to help. If I didn't hear, though, any like fundamental disagreement about some of these main principles and the importance of continuing to work together to turn them into meaningful action. So you all have heard what we talked about here. I know we just have a couple of minutes left, but before we wrapped up, I did want to leave a few minutes to see if there were any additional comments, guidance that people would like to give us as we go back and do this further work to get set for our last meeting, where we will follow up on some of the issues and components of steps towards access and coverage that we've discussed today, where we will have some revisions to the principles based on today's discussion. But any other issues that people would like to raise before we wrap up?
I'd be wrong if I didn't say that I did have one last issue, and that one major issue is the cost of healthcare.
Yeah.
As we've kind of done looking at everything else, but we haven't actually looked at the cost of healthcare and the insurance stakeholders of what we may see going forward as far as costs. Because I mean, even if you look at state health plans, recently retirees, if they come in 5 years, they won't be able to get their benefits as they retire from the state anymore. So things are significantly changing in that space with healthcare and healthcare insurance. And I don't think that we have really looked at the cost in those changes. Thank you.
And very important for sustainability too. Yeah. All right, Secretary Cohen, any final thoughts from you?
Thanks everyone for the thoughtful engagement, and really, I think, as Mark said, that there is so much alignment on these core principles. I think different ways of accomplishing those principles, and that's what we want to tease through. But I think the fact that we can come together to say we want to maximize coverage for the more than 1 million unfortunate North Carolinians who do not have access to coverage yet. And of course, coverage is not by itself the solution to all the problems. I think we know that. And thank you, Representative Cunningham. Like, there are other parts of this, of course, and I really appreciate this council focusing on the coverage piece of it, but then there are so many others I know that we need to tackle together. So great work, and appreciate everyone's ongoing engagement. I thought that small groups in particular were really helpful, so that we can really get into some of the details here. And I hope we can have more of that conversation as we continue to work forward, even beyond this council time. So thank you so much, and Happy New Year.
That's right. And really appreciate all the participation, especially in the small groups. While we are going to be doing some hard work between now and the next meeting to take account of everything that we've heard today, get set up for an effective way to spend our next time together. If you all do have further thoughts or things that we should follow up on with you individually or as a smaller group between now and then, please do let us know. We want to make this last meeting as productive as possible, building on all the time and effort you put in so far. So with that, I'd like to thank our team at Duke who helped put this all together. Hammy Tourson, Elaine Chen, Katie Huber, Kirk Williamson, Luke DeRocher, Rebecca Whitaker, and Will Blesser. And thanks again to all of you for making the time and effort to do this at a very challenging time for the state. Take care.